So now that you've done that, how do you, what are the things that you should ensure? Like I said, you want to auscultate the chest, ensure there's no main stem intubation, make sure air entry is good, check all the tubes, wires, ensure there's no disconnection, restart all the fluids, pumps, ensure everything is going well. Keep patient comfortable. It's very, very important, especially a prone patient on neuromuscular blockers is like a patient with a spinal deformity. You have to handle them with care, ensure that at no point there is no hyperextension of the arm. They are very prone to having brachial plexus injuries. Support the face, support the shoulders, support the elbow, wrist, knees, and the ankle. This is a position that is recommended for patients who are prone, and it's called the swimmer's crawl position, where we alternate the arm. One arm is kept flexed at 90-90, and there will be a support under the elbow and under the wrist of the flexed arm. The other is kept semi-rotated and in the lower position next to the buttock. Now, this position can be changed every 2 hours. It is found that this helps in both reducing the risk of brachial plexus injury as well as in pressure sores. The knee can also be flexed if required. Right. Now, once you have proned the patient, what are the things that you have to check? Make sure that there are no ECG electrodes, no EEG electrodes on the dependent part. Patient should not be lying on any tubes or devices. Very, very important. Try and slide your hand under the abdomen. The abdomen should be free. Your pillows under the patient should be adjusted in such a way that the abdomen is free. Like we discussed in the pathophysiology, the pressure from the abdominal contents can be eliminated only if the abdomen is lying free. This may be challenging in a morbidly obese patient, but otherwise it should be doable. The ankle position. Now, if you can see the image, the ankle should be kept dorsiflex, for which you can keep a pillow or a pad roll under the the shin, but the ankle should not be allowed to be plantar flexed. This is like a algorithm for proning a patient. It was published in the Critical Care Northampton Clinics. It's an excellent algorithm, especially if you're new to proning, you're in a situation where you realize you have to prone a patient. This is available freely online. It's even available on the MCRIT page. You can download it. It clearly defines proning into the 5 P's of prepare, plan, perform, protect, and perfect. Now, once proned, how do you look after these patients? Proning, a prone patient is going to be in that position for, like we discussed, anywhere between 12 to 16 to 18 hours, which is the larger part of the day. They will have to receive all their nursing care and feeds during this prone period. Ideally, it's advisable to keep these patients in a mild reverse Trendelenburg position and to ensure that there is no vomiting. If required, a small dose of prokinetics can also be used. Important to change the head and neck position every 2 hours. If you're using swimmer's crawl, change the hand positions every 2 hours. Like I said, patient on neuromuscular blockade should be handled with care. Enteral nutrition can be started maybe up to half an hour after proning, continued as the patient tolerates, until maybe half an hour before you decide to supine the patient. It is very important to always keep assessing for any pressure relief that is required. Have a thorough system for documentation of the skin assessment, weight bearing areas on the ventral surfaces during every shift. Eyes have to be kept moist and the eyelids should be kept closed. Like I said, there is a high risk for orbital edema. In fact, before proning, you tape the eyes shut if the patient is going to be sedated, paralyzed, and place eye pads over the eye. Foley is ideally positioned between the legs. The shoulder should be kept in a semi dropped position. You don't want to allow any shrugging. They have a high risk for developing a frozen shoulder. Now, with respect to COVID-19, I've already been going over it. Limit the number of people you expose. Try and restrict it to 5 people. Try not to go less than 5 unless you have an extremely experienced team. Safe proning is as important as effective proning. So limit the number of people exposed, try and keep it to 5. Very, very important is keeping a very, very tight seal on all the ventilatory circuits. Have enough length of ventilatory circuit tubing so that when you move the patient and prone them, there is no disconnection that happens. In the eventuality of a disconnection, immediately clamp the ET tube. Or if there is a planned disconnection for any reason, it should be avoided, but for any reason, the rule is clamp the tube, disconnect, reconnect, and then unclamp the tube. Please remember it's this in this order: clamp, disconnect, reconnect, and only then unclamp the ET tube. However, as far as possible, we avoid disconnections. Use inline suctions. Now, how do you know if your patient is going to respond to proning? Now, sustained improvement in gas exchange, it could be one of the various mechanisms which we went through, but predominantly, rather the common consensus is if there is a sustained improvement of the PaO2 of more than 10 millimeters of mercury on the same or similarly stable ventilatory settings, or if there is an evidence of alveolar recruitment, then it suggests that proning is effective. However, sometimes patients don't show these responses in the first 30 minutes to an hour, in which case we can give them up to 12 to 18 hours to respond. Now, when do you supine a prone patient? If a patient is showing response to proning, we can keep them prone for anywhere between 12 to 18 hours, even up to 20 hours. Ideally, supining should be done during shift changes. The reason is, at that point, there are many more hands available on deck. So even if there is, a complication, there is an emergent situation that arises, there's a code situation that comes, you have more people available to help. However, you don't always have to wait for 12 to 18 hours. If a patient very obviously fails proning, for example, there is no change or there is a worsening in the lung mechanics, there is a worsening of the hypoxia, or if there is a life-threatening risk, there's an arrhythmia, or if there is a tube disconnect, the tube slips out. In these cases, yes, they may require emergent supination. Once we've done all of this, we are happy with proning, we've decided to prone the patient for even 10 cycles. What are the complications that you have to worry about? Most prone patients, especially with a very bad lung, severe ARDS, are often on neuromuscular blockers, high doses of sedation. So there is probably a worry later about developing, ICU-induced neuromuscular weaknesses. There's increased rate of vasopressor requirement, again, possibly contributed because of the high dose sedation that we use. There is definitely an increased risk of tube displacement. It could be because of a tug on a line or because of the ET tube itself getting displaced. There is a risk of tube getting blocked because of an outpouring of secretions. There is a risk of pressure sores, brachial plexus injuries, facial edema, rare cases of retinal injury, vomiting. And from a COVID perspective, a tube disconnection, pouring out of secretions, and aerosolization.